Hello, it's Mark Kris from Memorial Sloan Kettering. I recently returned from a meeting of thoracic oncology physicians in California. And there was a lot of discussion about perioperative therapy. And I have to say that of all the areas of uncertainty right now, it is probably in that area. It is a time, though, of growing consensus that neoadjuvant therapy has so many advantages that it really makes sense and needs to be on the table for everybody. I think there's agreement on that, and that decision made about going forward. And I think we'll cover that in another topic. What I'd like to do, though, is talk a little bit about the history here. Why do you get neoadjuvant therapy? The history here at my institution is that our surgeons, very talented surgeons, would do complete resections of patients with bulky mediastinal disease. They would accomplish a complete resection. However, patients would succumb to metastatic disease. And the reason for the chemotherapy or other systemic therapy would be to control systemic disease. And when you look at all the results with neoadjuvant therapy, you see that that's where the advantage of it is. It improves progression-free and overall survival by controlling metastatic disease. There's really no proof that the chemotherapy facilitates surgery in any way, allows lesser surgeries, or somehow improves local control. It probably doesn't do that. It controls metastatic disease. So what got me thinking about this after that discussion was a paper in the New England Journal of Medicine about the use of perioperative chemo and radiation in patients with locally advanced gastric cancer. And what they saw was that adding in radiation did not improve either progression-free or overall survival, while it did improve both pathologic complete response rate and downstaging. Now, years ago, these issues had been looked at in lung cancer. And in truth is what you would expect is that in giving another local modality would not improve those outcomes, the important outcomes of survival, but would change some other outcomes, the path-CR rate and the downstaging. And what has been shown, and my colleague Matt Hellman many years ago reviewed the literature, and what he saw was that when you add in radiation, yes, you increase the path-CR rate, but you don't increase overall survival or event-free survival. And to me, it's obvious, because you can't expect a local modality to improve the control of micrometastatic disease. A complete resection completely controls local disease. So you sort of don't need radiation on top of it. It's two local modalities. Downstaging is very tricky. To be honest, you can't be sure that somebody is truly downstaged unless you know for sure that the lymph node that you're examining had cancer in before the neoadjuvant therapy and didn't afterward. Not having it afterward, you can't be sure that it was there in the first place. So that too has never been shown in lung cancer and not shown here in gastric cancer either. So some points. The first is, in lung cancer, there is a huge role for neoadjuvant therapy. There's every reason to give it. It's easier for the patient. You know if it's working. And it gives you, at the time of surgery, really important information about that outcome of the patient. But the information from pathologic CR is the information that comes after a systemic therapy. It's a systemic therapy that has been associated with overall improvements in overall and event-free survival, not necessarily the path-CR if indeed you've added in a second modality. It's very, very potent, and and now with the accompanying literature, particularly for melanoma, that the use of neoadjuvant therapy provides added benefits over the same drug therapy given postoperatively, I think there is more and more evidence that neoadjuvant therapy is the way to go. So I urge you to carefully look at the papers and please carefully consider neoadjuvant therapy in any patient with locally advanced disease. Always have it on the table. Again, it's not perfect for every patient, and there are always individual choices that need to be made. But for the first therapy to turn to, neoadjuvant chemotherapy or chemoradiotherapy in patients that are driver negative is the way to go.